Welcome, everyone. I'm Tony Caggiano, the Chief Medical Officer at Cognition Therapeutics. I'd like to welcome you to our next episode of Cognition Conversations. Today, we have three experts in the field studying dementia with Lewy body. Dr. Jim Galvin at the University of Miami, Dr. Lawrence Honig at Columbia University, and Dr. David Sprecher from the University of Arizona. Today, we'll be talking about different topics around dementia with Lewy body, particularly as they relate to Alzheimer's disease. So welcome everyone. I'd like to start asking you to comment around what you see as the differences and similarities between Lewy body dementia and Alzheimer's disease.
I think when they talk about dementia with Lewy bodies, or if we say DLB during the conversation, that's what we're referring to, is the second most common cause of degenerative dementia, affecting 1.4 million people. It's really the most common disease that many people have never heard of. So it shares a lot of features similar with Alzheimer's disease in that there's a progressive change in someone's cognitive abilities. But unlike Alzheimer's disease, it tends to be a little bit less of a memory disorder and a little bit more of what we call an executive attention disorder. So it affects people's ability to solve problems and think through things, lends them often to seeming more confused than you might expect. It's a little more common in men, whereas Alzheimer's is a little bit more common in women. So there are some differences, but I think one of the real challenges is that it's often a delayed diagnosis. So there's often up to an 18-month delay where after a patient has seen 2 to 3 physicians, and a neurologist is the most common doctor to make the diagnosis.
In general, we think of Lewy body disease as being more marked by motoric, that is, motor and movement problems, whereas Alzheimer's disease in its purest form usually doesn't have much movement problems. That being said, there are people with Lewy body disease who present, with just changes in cognition or memory and thinking. But nonetheless, the likelihood of movement problems emerging is high, and the likelihood of fluctuations is often high, as well as the likelihood of hallucinations. So there's certain features that clue us into the possibility that it might be more likely Lewy body disease. The other big feature that clues us into a possibility of Lewy body disease is the presence of REM sleep behavior disorder, sort of a mouthful, but situations when people act out their dreams at night, and that should always, in the setting of dementia, bring up the question of Lewy body disease. Alzheimer's disease in its purest form is marked by amyloid deposition, something called beta amyloid in the brain, and tau, or neurofibrillary tangle changes in the brain. Lewy body disease in its purest form is marked by Lewy bodies, which are accumulations of synuclein protein in the cell bodies of various nerve cells. So they're pretty different in their purest forms. Of course, a lot of people do have overlap, particularly in the pathology as well as in the symptoms, and may have features of both.
In our brain bank here in Arizona, we have people who, when they pass away and have diagnosis of dementia with Lewy bodies, almost all of them at that point, at their end of life, also have developed Alzheimer's disease. And we're hearing this from pathologists around the world, that the vast majority, 3/4 to almost all of people by the end of the disease course have both Alzheimer's and Lewy body dementia.
Jim, can you tell us a little bit about how the biomarkers in DLB are used for diagnosis, prognosis, or otherwise, particularly in your practice?
There are tests now that we can find the Alzheimer's pathology, but more recently now we have the opportunity to look for the Lewy body pathology. And so there are 2 main ways we can do this directly. One is through spinal fluid analysis. So they can do a special kind of seeding assay. In other words, they can test whether there is alpha-synuclein abnormalities in the spinal fluid. We could also do this through a skin biopsy. So we can actually directly visualize the Lewy body changes in the skin. We have some indirect measurements of Lewy body disease. So we can look for a special nuclear medicine scan called a DAT scan. And this can tell us whether there's a deficiency in dopamine, which is important for movement and Parkinsonian type of symptoms. We can also do a sleep study, as Dr. Honig mentioned before, to look for that REM sleep behavior disorder. So again, we're not directly looking at Lewy bodies, but it's so common in Lewy body disease, it's an indicative biomarker.
Dr. Galvin is the co-principal investigator on the grant which supports our study of CT1812 in dementia with Lewy bodies. Jim, why don't you tell us about the rationale for the design of this trial, as well as what we might have for reasonable expectations coming out of the trial?
I think this is really exciting. So this was a $30 million grant from the National Institute on Aging. To date, this has been the largest grant given to study dementia with Lewy bodies. And so there's a great unmet need because there are no approved treatments for dementia with Lewy bodies in the United States. So we have 1.4 million people who may have the disease, but no treatments really available specifically for them. So the SHIMMER trial is to test CT1812 in people with mild to moderate dementia with Lewy bodies. And people were randomized into 3 groups, 1 to 1 to 1. So one group got placebo. 2 groups got treated with CT1812, a 100 milligram dose or a 300 milligram dose. And they were followed for 6 months. We successfully enrolled 130 individuals. Now, what's important to remember about this study, this is a phase 2 study. So it's largely looking for signal and is the drug safe and well tolerated. So it's not powered to look for statistical differences between the placebo group and the treatment groups. What we want to see is a signal confirming that we're on the right path, that it's safe and well tolerated, and that the trial justifies further study. So this was a collaboration across multiple centers across the United States, as well as with the Lewy Body Dementia Association. So very, very exciting, very unique way of approaching the disease to really meet an unmet need for dementia with Lewy body patients.
Thanks for that review, Jim. So we've been very fortunate to have Dr. Sprecher and Dr. Honig as investigators on this study. I'd like to have you each comment a bit on the nuances of the study, particularly looking at the outcome measures that we use to assess the progression and hopefully see a signal with CT1812.
As a movement disorder specialist, I use a scale called the Parkinson Disease Rating Scale to give some granularity to all the different items that I test when I do a motor exam on a patient. So that's an integral scale that's used in this study. Another important problem is there can be multiple psychiatric symptoms, not just hallucinations, but also problems with agitation, depression, anxiety. So that's captured in a scale called the Neuropsychiatric Inventory. Lewy body dementia also can cause quite a wide fluctuation in the level of alertness and disorientation, as well as severe problems with daytime sleepiness. And we have 2 separate scales in this study, a cognitive assessment of fluctuation scale, as well as an Epworth sleepiness scale to measure those symptoms.
In this study in particular, the outcome scales, or the ways we measure and monitor people's change during the 6 months of treatment that you heard about, are a few in number. There's something called the Montreal Cognitive Assessment Scale, or MoCA. It's achieved a measure of fame in the news because it's been proposed that it be delivered to some politicians with an idea to test things like attention and drawing and memory and recognition of ability to name animals or objects. In addition to that, it's important to assess people's abilities to perform their activities of living. And so there's something called the ADCS-ADL, or Activity of Daily Living Scale. And that's also an important scale in this study. Finally, there's something called the Global Impression of Change Scale, and there are a variety of such scales available, but the basic idea of these scales is that the clinician looks at the entirety of the patient's performance in conjunction with the patient's caregiver, or study partner as we call it, and we ask, overall, do we think they're doing a little bit better, a little bit worse, a lot better, or a lot worse? And we do that at each visit.
Tony, if I might add, I think what's really important about what we've talked about so far is that in a disease for which there's no treatments and very few clinical studies, how important this study is, because by capturing a range of tools covering all of the different symptoms, we'll be able to define signals that will tell us whether CT1812 is successful and help inform us how to better design the next round of trials. So this is really, really a critical point. If you go in and you have one outcome and you don't hit that outcome, then you'll say it's not working. But in a disease where we really don't know what symptoms are going to be responsive, and that each patient has their own buffet of symptoms for which they present with, having a comprehensive view of the patient and then following that patient over the 6 months of the study will allow us to detect the key signals that'll tell us whether we're on the right path and how we could best help the patients in future studies.
Thank you. So as we look forward to data reading out later this year, I'm curious what each of you thinks would be successful within these different outcome measures.
We have colleagues at University of Florida in Gainesville that surveyed all the caregivers in their clinic. And on average, from the time when the symptoms started to when the patient passed away, was about 5 to 6 years. And so all of these symptoms can get worse quickly. So we have a unique opportunity here in that even though not everyone has the same symptoms, one thing that's common to the majority is that symptoms arise over time and get worse a lot more quickly than what we tend to see with other types of dementia for the most part. I think a real breakthrough would be if we even saw a difference in that overall, what we call the global impression of change. But even if we could see a signal with just one of those symptoms, that would really make us excited to see a larger trial and determine if this could be one of the first treatments for DLB.
So if I could just sort of then think about how I might, as a clinician, look at a trial and see what is good. I think 1, is a drug safe? And we can learn that from this study. 2, is a drug well tolerated? And we can learn that from this study. And 3, is, are there signals that give me hope that the drug used at the proper dose for a longer period of time in a larger group of people is likely to reach statistical significance? But remember, a phase 2 study is not powered to look at statistical differences. It's powered to see, are the outcomes different between the people getting drug versus the people getting placebo? So it's really important to set expectations of what a good phase 2 clinical trial looks like. And this study is designed to do that.
As opposed to a clinical trial perspective, maybe we can talk a bit about what we can expect from a patient perspective and a caregiver perspective, and what they're hoping to get out of these new experimental therapies.
One of the really important things that I have to clarify from the outset when I'm talking with patients, and in particular their families, is that particularly with a condition where we don't have any proven treatments, the chance that they're going to directly benefit from being in the study still isn't that high, but we can still provide them hope. And that hope that they're part of that fight to find that first treatment is still important to them. Another really important thing to them is to know that if this study is successful, that the company that we're partnering with will have that additional support from sponsors, from investors that will allow them not only to do that phase 3 study, but also determine what are the longer term effects of continuing that treatment beyond just that 6 months they were in the trial.
As David said, we're always hopeful that with good biologic rationale, that the drug being tested will be beneficial, and that it will continue on the course of drug development and end in a marketed drug. This is always particularly pertinent, as you heard, in a disease such as Lewy body disease, where not only is there a wide variety of symptoms, as we've been talking about, but there really is not any disease-specific treatment or too many treatments that provide significant benefit for some of the symptoms.
One of the things when I have conversations with my patients about both clinical trials and after a medicine is approved is, what are the realistic expectations when we're dealing with a chronic degenerative disease. So one, can we slow down the progression of disease? Two, is the drug safe and well tolerated, so it's not causing any adverse side effects? Three is maybe we might be able to improve some things. So there might be some things that actually show some improvement. And four is when we put all these things together, can I improve the quality of life for my patient? So even if they're still living with disease, are they better off for being treated than what we did before they were treated?
As you know, we recently reported data from our SHINE trial looking at the effects of CT1812 in individuals with mild to moderate Alzheimer's disease, where we showed very nice effects of slowing of progression with CT1812 treatment across a variety of outcome measures. I'm wondering if you think this has bearing on the results of the SHIMMER trial, which we'll read out soon.
Well, it has a lot of bearing because it's the same drug, and it's targeting the same concept, is that the sigma-2 receptor, which is affecting the ability of an abnormal protein to bind to the oligomeric receptor. SHINE was a phase 2 study as well. It was a short study with a small number of people. And so the most important thing is, one, is it safe and well tolerated? And two, is there a clinical signal? And in fact, there is. So all the outcomes showed numerical differences between the treated group and the placebo group, particularly when you pooled the data of the two groups together. And that effect size, that difference between the treated and the untreated group, was as big, if not bigger, than the currently approved medications to treat Alzheimer's disease. So the only limitation of the SHINE study was that it didn't have 1,200 people in it.
In cases where a drug is proposed through its biology to affect more than one disease, it's certainly of interest when we see a signal for efficacy in a single disease and wonder whether it might work in a related disease.
Yeah, someone who doesn't do trials regularly in the Alzheimer's disease population, really focused in the atypical causes of dementia and Parkinson's and Parkinsonism. I was still really struck by the fact that just about every single item that was tested in the SHINE study showed a signal. So for a study medication that is supposed to protect the brain cells from both toxic effects of the Alzheimer's proteins and the Lewy body protein, that's very promising. But we have to say we're cautiously optimistic until we see the results, and if they're positive, that we see the outcome of that bigger trial that really has enough participants to show that it's a true meaningful effect.
Well, I'd like to thank each one of you, Dr. Jim Galvin, Dr. David Sprecher, and Dr. Lawrence Honig, for participating in this cognition conversation. It's been extremely informative, and we look forward to the results of our SHIMMER trial coming out later this year. Thank you.
Thank you.
Thank you.